We are live.
Yeah, great. Good evening, friends. Welcome to Indian Arthroscopy Society webinar today. Alan Getgood is a renowned arthroscopy and orthopedic sports medicine surgeon. He's from Canada. He's going to speak today on meniscus repair for the posterior lesions. Dr. Shreyash will kindly introduce Dr. Alan to all of us, and then he'll share the screen and we take forward his presentation. Shreyash.
Oh, thank you, IPS Oberoi, and hello everyone, and welcome to webinar number 102 on meniscal repair for posterior lesions. Where are we today? With better understanding of the importance of meniscal function, meniscus surgery has come a long way from excision to preservation. The concept of meniscal preservation has guided evolving modern treatment methods for meniscal tears. Posterior meniscal lesions are becoming increasingly recognized in clinical practice as a source of profound pain and dysfunction, resulting in ongoing advances in its management. And to shed light and address this area of controversy, we have Dr. Alan Getgood from London, Ontario, Canada. He is well-renowned internationally, and he specializes in complex soft tissue reconstruction of the knee. He practices at the Fowler Kennedy Sports Medicine Clinic and is the Associate Professor in the Division of Orthopaedic Surgery, University of Western Ontario, London, Canada. He completed his primary medical degree at the University of Edinburgh, followed by orthopedic residency and research doctorate at the University of Cambridge. His fellowship training included time in London, Ontario, Banff, Alberta, and Coventry, UK. His research work focuses on knee biomechanics and clinical outcome studies. He has authored over 110 peer-reviewed articles and numerous book chapters, and was awarded the Isakos Albert Trillat Young Investigator and Jan Gilquist Awards in 2017 and 2019, respectively. And in 2019, the O'Donoghue Award from AOSSM for his work on the stability study, which we are all very well familiar of, a randomized controlled trial which focuses on the utilization of lateral extra-articular tenodesis augmentation of ACL reconstruction. He's also on the journal board of the AOSSM, the editorial board of the AJSM and the ESCA journal, is a member of the knee committee of the Isakos, and also a member of the ACL study group, and is actually elected as the program chairman in 2022, and the Herodicus Society as well. So really he is an apt person, and we are very grateful on behalf of the society to have him today, and we welcome him and invite him to please share his screen and give his talk on meniscal repair for posterior lesions. Where are we today? Thank you.
Okay, Shreyash, thank you very much for kind introduction and invitation to join you this evening. And thank you to the rest of the committee again for extending the invitation to give this webinar. So I'm going to talk about posterior meniscus lesions and really what my interpretation of that would be. These are my disclosures, none of which are really that pertinent for this particular talk. What I thought I'd do is I'd talk a little bit through some basic meniscus anatomy and then maybe get into a little bit more about the posterior meniscus. I'm going to talk primarily on root tears, but also want to talk about radial tears and ramp lesions, because I think these are very common, or at least they're being talked about very commonly at the moment, very topical. And it's something that we all need to be aware of. And there is some controversy around this area as to what is the best management. And then, of course, afterwards, we'll have some question and answers. So if we just look at the meniscus anatomy and just go through that, here, of course, is the medial meniscus. And of course, these are the medial meniscus being somewhat more C-shaped than the lateral meniscus. Both menisci have got very firm root insertions, both posteriorly and anteriorly. And these connect the circumferential fibers of the collagen fiber architecture that allows compressive forces to be able to create into these sort of hoop tension stresses, which will be able to then distribute load across the joint and reduce the amount of contact stress on the articular surface. The medial meniscus, as demonstrated here, is actually quite firmly placed in situ on the medial side due to the coronary ligament attachments. And so there's very little movement. So not only is it a load distributor, but also creates some secondary function for stability. The lateral meniscus, on the other hand, tends to be a little bit more mobile. You can see the anterior horn of the anterior insertion of the lateral meniscus its close relationship with the anterior cruciate ligament, with the posterior insertion of the lateral meniscus coming really forward, just anterior to the lateral tibial spine. And in many ways, actually, there's a number of there's 2 or 3 different attachments of the lateral posterior horn, which will come really very close to the ACL insertion. And you can see there just the relative mobility of the lateral side versus the medial side, which is important for stability. Here we have the popliteus hiatus, there's the popliteus tendon, and you got the popliteal meniscofascials, both the superior and inferior, which will also create some stability. And there is a lot of discussion about their role in terms of controlling rotatory stability of the knee, and what we may see at the time of ACL injury and ACL reconstruction being a widened popliteal hiatus. The posterior insertion of the medial meniscus has a very important relationship with the PCL. You can see the shiny white fibers of the posterior insertion of the medial meniscus. And of course, if we when we're doing PCL reconstruction, and if we drill our tunnels a little bit too proximal, there is a significant risk of damaging that posterior root insertion. So again, we've got to understand the anatomical relationships of all these different structures. Equally, when doing an ACL tibial tunnel, very important not to go too lateral, as there's a significant risk of damaging the lateral meniscus anterior tibial insertion. With regards to the lateral side, we also got to remember about the meniscofemoral ligaments. These are important in terms of helping control rotation, as well as posterior translation, as well as providing stability for the lateral meniscus. And this is something we should really think about when looking at lateral meniscus posterior root tears at the time of ACL injury. We may not see much in the way of extrusion because of the insertion of the meniscofemoral ligaments. But with the meniscus torn, the root insertion torn, there may be an issue with increased anterolateral rotation. So the posterior medial meniscus has come under an awful lot more attention over the last number of years. And a lot of that is due to the emergence, or at least a better understanding, of ramp lesions. So ramp lesions being an injury to the meniscocapsular attachment, as well as the meniscotibial ligament of the posterior medial meniscus. And this is a really nice study from Leprade, showing those relationships. And what I think is important is to understand the relationship of the semimembranosus attachment. So semimembranosus is going to be coming in just on that meniscocapsular ligament, and whether or not the ramp lesion is being caused by a dynamic contraction of semimembranosus at the time of our ACL injury. Again, that is something that is somewhat debatable. But also, we also see this meniscotibial ligament, which is likely the cause of the problems with having increased anterior translation when we're seeing these particular injury patterns. And again, just to draw our attention, we've got the meniscotibial ligament, the meniscocapsular ligament, and this semimembranosus attachment, which may be causing, or may be the root cause of our ramp lesion. The lateral side has also come under a lot more scrutiny. Again, here's this, again, a study from Leprade, again showing that the lateral meniscus has a meniscotibial ligament, and then these superior and inferior popliteal meniscofascials, which all have this dynamic relationship, which will control some stability of the meniscus, but also allow it to have a little bit more anterior posterior excursion, which is important to be able to achieve deep flexion. And then again, from when we're doing our arthroscopies, this is what we're going to see from the anterior view. So we're actually not going to really be able to see a lot of these structures very clearly. You can look down the lateral gutter and try and get an idea if there's any abnormalities here, and look to see whether or not that the popliteal hiatus is widened. And I think in time to come, we're going to see a better understanding of really what that means and whether or not we have to address it arthroscopically. I thought I would just maybe talk a little bit about some sort of contemporary meniscus repair techniques, because all of these techniques are going to be utilized when we start to get into more complex treatments or treatments of more complex tear patterns. So, of course, when we're thinking about decision-making for any sort of meniscus tear, we have to take each tear as well as each patient based on their considerations and indications for repair. So the ideal scenario would be a tear of the meniscus with less than 4 millimeter rim, where we're trying to get into the more vascular tissue. But of course, when we talk about radial tears, which I'm going to speak about a little bit later, then actually we can really push the envelope, pushing the boundary, and maybe getting into more avascular zones. And we do see actually some healing, particularly if we can provide some biological augmentation. So certainly in terms of the biomechanics of the meniscus, we do want to think more about being more aggressive in the lateral meniscus than medial, because of the importance of the lateral meniscus in terms of actually its ability to share load, approximately 70% of the load in the lateral compartment. And of course, if we lose the lateral meniscus, there's significant risk of increased cartilage stress. So we really, in young patients, we really want to be aggressive and try and maintain the meniscus integrity. Surgeries or meniscus repair tends to be much more successful if undergoing concomitant ACL reconstruction, whether that's the effect of the increased biological stimulus from having a lot of blood in the knee after the surgery, but also providing a more stable environment for healing. And then, of course, we got to think about the cartilage status. We may not be as aggressive in the more arthritic picture, and also the alignment, which is very important when we're thinking about root tears. And then in terms of the geographic position of the meniscus tear, the different techniques that we might want to use, the posterior third and parts of the middle third may be appropriate for all inside sutures. When we start to get more into the middle and anterior, we're thinking inside out. And then, of course, outside in may be appropriate for the more anterior third lesions. But of course, this is all of these techniques can be mixed. And I think it's important when we're getting into more complicated tear patterns and repair strategies that we're fully versed in being able to use all of these different techniques. I like a pretty simple setup. I don't use a leg holder, so it's effectively just using a side post and often a foot roll. It's important that we have appropriate instrumentation on the set, retractors. You need time. I think the clock is often a problem, certainly in my OR. We have very strict time schedules. And so therefore, you've got to really try and give yourself enough time to be able to do these surgeries. And then access to be able to get to the posterior medial compartment, posterior lateral compartment, how to actually open up the joint a little bit better. And I'll go through that in a second. Open approaches, I think we have to move away from this concept that a lot of people are just using all inside devices. I think all inside devices have their role, but still the gold standard procedure is still going to be the inside out sutures, in which case then we need to be able to understand how to be able to access the posterior medial compartment. And so with the posterior medial approach, retracting sartorius and then using the interval between medial head of gastrocnemius and the capsule, whereas the posterolateral approach is between ITB and biceps, and then again going anterior to the lateral head of gastroc and deep to the capsule. And that will give you nice access into the posterior aspect of the knee where you can get a retractor and protect the neurovascular structures. In terms of the suture configurations with simple vertical tears, my preference for sure is vertical mattress sutures. And a general rule of thumb I use, if I'm going to put for every 2 sutures I place on the superior surface, I like to place a further suture on the inferior surface, and that's to prevent gapping on the inferior surface with too much tension being applied on the superior surface. So you really want to try and balance the tensioning. And then, of course, depending on, you got to think about the neurovascular structures tend to sit a little bit more lateral. So when aiming for the lateral meniscus, going from the contralateral medial portal will be safer because you're basically directing your needles away from the neurovascular structures. So swapping your portals in terms of your viewing and your working portal to be able to give you safe and easy access is important. MCL release, I tend to do a pie crusting quite regularly, not only for treatment, but also for visualization in the tight medial compartment. So this is using an 18 gauge needle in the meniscal femoral portion of the superficial MCL and the more posterior fibers. And that will give you a gradual opening of that medial side. Again, this is something that's been very topical of late and has shown really that in post-operatively not to be any significant downstream effects. Introducing biology into any tear is important. So rasping, trephination, all of these things are important to be able to get an appropriate repair. The all-inside repair, lots of different devices out there for use. And again, when using these, I tend to use these in the posterior third, particularly I isolate the posterior third tears, and I also use them for ramp lesion repair, which I'll show a little later. And again, I tend to use for every 2 implants on the superior surface, I'll tend to put 1 on the inferior surface. And as a general rule of thumb, if I'm going to use more than 3 all-inside implants, that is a tear that's going to require an inside-out suture repair. So I tend to use a maximum of 3 in a meniscus. If I'm going to need any more than that, then I would tend to use inside out sutures, because really just the tear is probably not stable enough to be able to manage this particular pattern. This is a nice video from Dr. James Robinson from the UK, just really illustrating the use of this particular device. Really, it's an active deployment device. So it's really quite a straightforward procedure to use. But you can see by putting them on the superior surface, it tends to lift the meniscus up. Hence why it's important to put a further device on the inferior surface to cinch it back down again. So as I said, for any meniscus tear greater than 3 to 4 all inside devices, I do a hybrid repair. So I'm going to add in some inside out sutures. So what we really want to talk about today are the posterior lesions. So first of all, I thought I would talk about root tears and why are they important. And this really goes back to our understanding of the biomechanics of the meniscus and its load sharing capabilities. And these are 2 studies that, again, performed by Rob LaPrade, but showing just looking at association of intact meniscus on the lateral side, as well as the medial side, root tear, as well as radial tears. And what you see with this sort of tech scan profile with contact pressure, you essentially get an increase in contact stress in the lateral compartment with a root avulsion, and then again with radial tears, which is improved with root repair and radial tear repair. And you see the same on the medial side of the knee. So clearly very important that we try and maintain the structural integrity of the meniscus. Lateral root tears, another important thing to think about is also the secondary function that they have, which is providing stability. So on the lateral side, a study from so my lab with Tim Lording, who's a fellow at the time, he's now back in Melbourne. We did a cadaveric study and looked at simulated pivot shift in the presence of a lateral meniscus posterior root tear, and we found that in flexion angles closer to extension, that the lateral meniscus had an important role in controlling anterolateral rotatory laxity. And this was similarly seen in a study by Hide Koga from Tokyo. The medial meniscus, so the lateral meniscus, I think you can think of root tears as being more for kinematics and controlling stability. The medial root tear is much more of a problem in the degenerate knee spectrum. And this is where we're sort of thinking about this sort of what LaPrade has described as silent epidemic. So medial root tear and an onward progression of degenerative change. And this is actually just an example of a patient of mine who actually I saw her when she was about 62 years old. And she presented with the MRI just on the right-hand side here with this significant flattening of the condyle. She had this increase its signal in the medial femoral condyle, of course, significant medial meniscus extrusion, and ended up having to do a hemicap, just a partial resurfacing on her. She got really good pain relief from that. But when we look back at her previous MRI scans that she had prior to being referred and being treated elsewhere, you can see at that stage, this was about 6 years prior, she had a medial meniscus extrusion. And if we just look at the most posterior cuts, you can see a posterior root tear. So clearly, she is someone that developed a root tear and then went on to have really quite severe degenerative disease. And one would question, if we had got to her sooner, could we have done a root repair and maybe saved this knee? And that's the big question. How common are root tears? Well, the lateral meniscus root tear is about an 8% prevalence. So about one, you're going to basically summarize to say 1 in 10 ACL reconstructions that you do, you'll see a lateral meniscus posterior root tear. On the medial side, 10 to 21% prevalence, and they're much more likely to result in chondral injury. And of course, the association with osteoarthritis and spontaneous osteonecrosis of the knee has been well documented. So risk factors and how we try and make the diagnosis. So again, this is more focusing on the medial side. So medial root tears, degenerative pathway. So it's associated with varus alignment, higher BMI patients will often complain of a sudden onset of pain. For me, it's the classic, somewhat overweight, middle-aged female steps off a sidewalk and feels a sudden pop, a sudden sensation in the knee with increased pain. Or a gentleman who's working in a sort of a laboring type job who bends down in deep flexion and has a sudden onset, sudden popping sensation. That's the concern, and then the pain that doesn't settle down. So atypical from your standard meniscus tear. Physical examination often won't find very much. You may have some joint line tenderness. There is this extrusion test on applying varus stress and noticing that extrusion as the meniscus pushes out to hit your fingers with your fingers placed on the joint line. I think the key is having a low threshold based on the clinical presentation and the history, in which case that's where you might want to get imaging such as MR, and the MR you'll be looking for extrusion, and then this so-called ghost sign as you go through your sagittal sections, essentially that your meniscus posterior root just disappears. Okay, so that's something that we have to have a high index of suspicion. For the lateral meniscus root tear, you just got to look for them. They're not often necessarily easily picked up on MRI scan, and you're going to find them at the time of ACL. You just got to look for them. 1 in 10 ACLs, you're going to find it. How should we treat them? Again, thinking more along the lines of the medial meniscus root tear, comes down to symptom profile. We've got to understand their alignment. I know in the Indian subcontinent, varus alignment is a big issue. And, we're very pro alignment correction in our center. And so we're going to mostly focus on realignment osteotomy with concomitant root repair. So you've got to think about that concomitant pathology. So alignment is key. Big question that comes up is, can we leave them alone? Can you treat them non-operatively? And there's been a number of studies, and these are mostly just case series. There unfortunately are no really high quality comparative randomized studies for the treatment of medial meniscus posterior root tears in the literature at present. I actually am collaborating with Jorge Chala from Rush in Chicago, and we're setting up an RCT to look at this particular problem along with Laprade and Aaron Critch here from Mayo. But at this point in time, the evidence is somewhat sparse. But what we do know is that if you do leave them alone, arthritis tends to worsen over time. We also know, which is very clear, if you do have a root tear and you perform an arthroscopy and a partial meniscectomy is performed, which in effect is a subtotal meniscectomy by virtue of the fact that the root insertion is not present, again, patients do worse. And the big question is, well, what if you do a repair? Does it really alter the natural history? And this study is quite nice. This is essentially a longitudinal study, but also an economic analysis that showed that with root repair, patients that tend to be more free from symptoms of osteoarthritis for a longer period of time compared to patients who've had non-operative treatment, or worse still, have had a meniscectomy. And also in terms of survivorship from not requiring a total knee arthroplasty, again, is a little bit better with root repair. But you still see that gradual decline. So there still is an issue. Their economic analysis also showed that it was cost effective to do meniscus root repair. But really, we do need some better comparative studies. In terms of data for lateral meniscus root tears, it's a little bit scarce. So this is just some data that we haven't published yet at the moment, but hopefully will be coming out soon. This is some data from the stability study. So in our study, where we had 618 patients, there were 42 patients who were found to have a lateral meniscus root tear. 22 of those were in our particular center at Fowler Kennedy. And so we did across the whole study group, we looked at the repair rates, but then also in our center, we looked at MRI. And what we found essentially with patient-reported outcomes, that there were no difference in patients between those that had their ACL treated with no root tear versus those that had ACL treated with a root repair. So the IKDC and KU scores were comparable, and also the healing rates was actually excellent. There was only one patient on MRI that looked like their meniscus root tear had not healed adequately, and even then it was partial healing. We also looked at quantitative MRI, so looked at T1 row and T2 relaxation, and found that between 1 and 2 years, the T1 and T2 relaxation times remained consistent. So there didn't seem to be any decrease, or at least increase, or there was no degeneration of the articular cartilage over that time in patients who had a root repair, which would maybe suggest that it's hard to make a firm conclusion, but it maybe would suggest that the articular cartilage health is being maintained over time. How should we perform a root repair? Again, lots of biomechanics time zero studies in cadavers, whether we're looking at locking cinches or locking loop stitch versus a cinch suture. There's really no difference in this particular study from Mayo. Leprad has shown in their study that a double tunnel with a trans-tibial tunnel has greater load to failure. But if you actually look at the numbers, one really has to question whether or not those differences are clinically significant. But certainly there's lots of different options. I really like this study, looking at both the position of the sutures, so whether or not you put the material into the ligament, the transition zone, or actually in the body of the meniscus, as well as the type of material. So it's from James Robinson. And what they found is that tapes had a greater maximum load to failure. So some form of suture tape may have a better option in terms of actually being able to hold the repair, as well as the tear location being placed in the body had also a greater load to failure. I would just caution though with that is that if you're putting your sutures into the body of the meniscus, but then bringing the suture material over to the root insertion site, that you actually might over reduce the medial meniscus. That may itself cause some problems. So you have to be a little careful about that. So here's an example. My practice is much more focused on ligament reconstruction rather than degenerate. I don't see that many patients with degenerate knees with root tears at an early enough time point where I'm able to do something about it. Most of my patients have already got some more degenerative disease and they're doing osteotomy as opposed to root repair. But I do a lot of root repairs on the lateral side. So this is a 26-year-old guy who is undergoing a revision Acl reconstruction. You can see from his MRI scan here, you can see that the posterior root is lifted off. There doesn't seem to be any insertion. Clinical examination, significant anterior laxity, as well as rotatory laxity. So, and this is the technique that I use for a lateral root repair. So here you can see meniscofemoral ligaments are intact, but the root insertion is not present. So we're probably not going to see much in the way of extrusion. But this is more of and you can see the articular cartilage damage there on the lateral femoral condyle and extension. So this is going to be an issue of controlling stability. So I really want to try and get this meniscus root repaired. So using a curette to remove the articular cartilage from the root insertion, and then just shaving away some of the debris, and then using another spoon curette just to basically clear that out. So I'm down to bleeding bone. I've used a root guide there to insert a 2.4 millimeter guide pin from the anteromedial tibia. And if you just reduce the angle of the insertion to about 40 degrees, that will avoid your ACL tunnel. And then we're passing a tape using a proprietary device. And for this one, you can use, for sutures, I used to use a sort of more of just a luggage tag sort of suture. This I'm doing a horizontal mattress. It's really nice and easy to do. And then a second, I can do a second suture, which will loop over the top of that and sort of lock in place like a modified Mason Allen. And using this device, it's pretty straightforward to pass these tapes in this mattress fashion. And then once the tapes are in place, I can then place I actually tend to just use a PDS meniscus suture as a shuttling device. So there's the meniscus suture going up the tunnel. I grab it with the grasper, and then we'll shuttle those tapes down through the tunnel and tie them over a button on the anteromedial proximal tibia. So that's the technique that I tend to use for my meniscus root repairs. Now, this is a video from Charlie Brown from the United Arab Emirates. And this is an example of a case where a patient has had this is a root tear plus an ACL deficient knee, high-grade pivot shift. And what Charlie's showing here, he's now done the root repair, but hasn't done the ACL reconstruction yet. And already just by doing the root repair, it reduces the degree of anterolateral rotatory laxity. So it reduces the pivot shift, not completely, but it certainly helps. So I think that's a really nice visualization of what we're trying to do there. In terms of rehabilitation, I tend to keep patients flat foot touch weight bearing for 6 weeks with a range of motion of 0 to 90 degrees. Anything greater than 90 degrees will start to put increased pressure on the meniscus. So I want to try and stop that from happening. And particularly in the medial side, for medial meniscus root tears, I'll put them in an unloader brace for a little longer period of time. Even in the neutrally aligned limb, got to bear in mind that the center of mass still acts medial to the center of rotation of the knee. So you're always going to have that adduction moment. So an unloaded brace will likely help. So we're going to move on to something a little bit different. So we're starting to get probably a little bit more challenging. So this is a young girl who unfortunately had this injury where she had a ACL MCL injury, and at the time of her MRI scan, really had a lot of damage. You can see the MCL injury, ACL's gone, but also this really significant radial split of her lateral meniscus, as well as the impaction injury in the lateral femoral condyle. And at the time of the arthroscopy, we can see this gapping of the posterior third of the lateral meniscus. So this is no longer a root tear, this is actually away from the root. And these are really a challenging problem. So why repair radial tears? Well, very similar to what we talked about with the root tears. It really changes the mechanics of the joint and the ability to withstand forces. And this study is pretty interesting in that as you go further back to the root, the amount of contact pressure changes. So we get increase in pressure, the more in greater flexion, but also a reduction in contact area. So you get point loading as we get into deeper degrees of flexion with different configurations. So going from mid-body to posterior third to root. So again, important to try and preserve the function. In terms of radial tears, I think it's gone, the discussion has changed from should you do a repair versus how to do a repair. And there's lots of different techniques out there, whether just simple horizontal mattress sutures, or what's becoming a little bit more prevalent now is doing more what this technique is called a tie grip, or it's been called a hashtag repair or a rebar repair, whereby adding in these vertical mattress components and then horizontals either side of it as a ripstop will give a really nice repair. So this is just an example of that. So here I'm using inside out sutures with a suture with the cannula. So 2 vertical sutures, and then placing the horizontal mattress across those as that ripstop type feature. Another study from the Prad, again, biomechanics study, looking at these different types of repair constructs. And what Rob has done is he's really advocating in some scenarios, certainly in the medial side, looking at a tibial tunnel, a transtibial pull-out technique, which really helps dock these sutures in. And when combining that with these ripstops or rebars, they tend to get a really excellent load to failure. So that's something that I have used. So this is an example here in this scenario where there's a 34-year-old female with this really complex tear pattern where there's a vertical plus a radial tear component about 1.5 centimeters to 2 centimeters away from the root insertion on the medial side. And this is a really challenging knee by virtue, if this was a meniscectomy, we're essentially doing a subtotal medial meniscectomy at the time of an ACL reconstruction. So for this case, I actually did a tibial, transtibial pull-out repair. So using the using the curette to remove the articular cartilage at that insertion, I'm going to drill a tunnel. And then I'll just move on to the next one. So, and then we'll basically pass some horizontal mattress sutures using a suture passer. So again, this is a self-grabbing suture passer. I'm going to pass this in a horizontal mattress fashion and then shuttle these sutures down into the tibial tunnel. Okay, so I'm just getting that suture as well. Okay, passing it again through the other side, being very careful, trying not to damage the articular surface. And then we're going to pass these down in through the tibial tunnel. So here now drilling a tibial tunnel using a root guide. And once I've drilled that tunnel, I grab the passing suture, and then we'll shuttle all those sutures down. And then once that's coming in, that should all dock in. So hopefully we'll be able to see that. There it goes. And then that just pulls the repair together. And then after this, I just added some vertical mattress, all inside as well as outside in sutures. So there's the outside in sutures going in to repair the vertical component. That actually got a really nice repair, both on the superior surface and the inferior surface, to dock that repair in. And I did something very similar. So that girl that I showed you playing volleyball, this is a little bit more controversial. This is a really tough tear to try and get together. So I did use a transtibial technique. But this is on the lateral side, and there is, of course, a risk of over-constraining lateral meniscus movement. So I think certainly on the medial side, it's a great technique. I would sort of suggest some caution when using it in the lateral side. And if you do use it on the lateral side, you really don't want to pull it down too hard, so you still preserve some of the lateral meniscus motion. Rehabilitation, again, very similar to the root repair. So 6 weeks of flat foot touch weight bearing 0 to 90 degrees. And then from 6 weeks on, starting to increase motion and weight bearing with the unloader brace on the medial side again, rather than the lateral. Radial tear repair outcomes, study from Mayo Clinic, really showing that you can think of these as being now comparable to repairs of a bucket handle tear. So I think as I said, we're moving away from should you to how do we do it? How do we get these repairs? Because they definitely can heal. And this is just an example of a second look arthroscopy where after a repair, this is again from Aaron Critch, showing that this tissue can heal, maybe not so much on the most inner margin, but certainly in the periphery where there's good vascular supply, then that certainly is a possibility. And then lastly, I want to talk about ramp lesions. Again, I think this is probably a little bit more controversial in terms of how to manage these. What are ramp lesions? Well, there are a posterior lesion. Again, we talked about it earlier on, but this sort of the meniscocapsular junction, but also the meniscotibial ligament. And it's the meniscotibial ligament, which is likely the key role in controlling the anterior translation. They've anything from a 9 to 40% prevalence. And why is there such a wide spectrum of these? It's really primarily because of how you go look for them. If you look through the Gilchrist approach underneath the PCL, I think you will see large, probably more clinically relevant ramp lesions. If you look through a posteromedial portal and probe it, and even as Sonoricote would suggest, bringing a shaver in and removing some of the synovial tissue to view those, I think you're going to find an awful lot more. The question is, are those more clinically, or are they less or more clinically relevant? Classification has been produced. And essentially, I think if you, the partial tears, so the type 1 and type 2 tears, most likely can be left alone. I think that's most important if you don't have increased anteromedial translation or rotation. I'm going to talk about this a little bit later, is to think about what's stable and what's not stable. If you have an unstable type 3 to 5 ramp lesion, then I would advocate a repair. How do we make the diagnosis? MRI scan can be useful. And I think with more advanced 3 Tesla imaging and in-plane sections, that's been shown from HSS that they can get up to 85% sensitivity and specificity using their techniques. You can pick these lesions up, but I think you just have to have a high index of suspicion and go looking for them. But you may see this increased signal, the posterior aspect of the medial meniscus, as well as the bone bruise. The bone bruise is often a key aspect of a ramp lesion, but of course, it's really the arthroscopic examination which is going to be key. Why should you repair? Well, this is one cadaveric time zero study that would suggest why you should do it. Well, if you do an Acl reconstruction in the presence of a meniscus ramp lesion, it's not controlling anterior translation until you do the meniscus repair. So that's essentially improving kinematics and reducing the amount of load on the ACL reconstructed graft. So that would be an argument. Clinically, this is a study from Roman Cell, and they looked at a series of patients of ACL injuries and looking at their clinical examination at the time of under anesthetic. And they found that patients with a ramp lesion had tended to have an increased amount of rotatory laxity and anterior translation. So they were certainly more unstable. And a study from Laprade, comparing ramp repair versus patients without a ramp repair, they found that they had comparable patient-reported outcomes. So essentially, they were definitely no worse. And so their argument was that if you repair them, they can be as good as a primary ACL. But of course, there has to be the yin with the yang, and essentially why you maybe shouldn't repair a meniscus ramp lesion. Well, here's an example of a study from Pittsburgh, Volker Mussel, when they did a simulated ramp lesion and then looked at the kinematics as well as the in situ forces in the ACL, they found with the ramp lesion had very little impact on these forces and kinematics. And they suggested that lesions less than 25 millimeters were maybe stable, maybe not an issue, and therefore you could leave them alone. And this is something that has been advocated from HSS, from the group in New York, were suggesting that stable lesions really had minimum impact on anterior laxity or rotatory laxity. Systematic review by Mary Mulcahy in Tulane in the United States, very similar findings, showing that the basically all inside anterior fixation technique had no differences in outcomes versus a suture hook. Posterior repair, no difference in outcomes, with slightly increased risk of complications by doing a ramp repair. So I think we've got to bear this in mind, that maybe not all lesions need to be repaired. And really we should be focusing on patients that have got higher grade rotatory laxity, where you're trying to, again, optimize your ACL reconstruction results. So I am an advocate of ramp repair, but I think it's not for every single lesion. And if it's a pretty stable knee, low grade laxity, then I think these are lesions that maybe can be left alone. So here's an example of a patient of mine. He's a 24-year-old football player. So and had a 6-month-old ACL injury. He had a grade 2 Lockman with a grade 2 pivot, very low grade MCL, but he also had some anteromedial rotatory laxity. So he had a positive dial test, but that's based on him having anteromedial rotatory laxity rather than posterolateral rotatory laxity. His radiographs are pretty unremarkable. Stress radiographs showed he had very low grade MCL, as I said, but not enough to warrant doing a reconstruction of his MCL. And you can see here on his MRI, there's just a little bit of high signal in the back of the medial meniscus. So this is just examination under anesthesia. Again, this shows that he had this increase in anteromedial rotatory laxity, both at 30 degrees as well as 90 degrees of flexion. His arthroscopic video, you can see you can't see very much from a point of view from his anterior approach, but when we look in the back of the knee, you can see this ramp lesion. So he's a positive ramp. We did an MCL release. I've showed that before. I'm just going to quickly jump through in terms of getting diagnostic access. So sometimes it's difficult to get into that posteromedial space. So this is actually really quite tight. One very nice little trick to be able to get in there is actually drop the leg over the side of the bed and push the knee into varus, and that paradoxically will open up the knee, because the knee is then pivoting off of the most medial aspect of the medial plateau. That gives you nice access. Posteromedial portals can be very helpful in depending on the type of repair that you're going to do. So if you do like to do a posteromedial approach, then I just put a needle through and then put the knife over the needle, and then you can use a cannula, or it can just be placed. This is just using a switching stick and then putting a cannula over the top of that. So that's a very nice, easy for access. This is a video that was shared with me by Dr. Tom DiBardino. He tends to use a suture hook at the back to shuttle a suture and then repair his ramp lesions, and using this technique with a posteromedial portal. My preference, as I said, is an anterior technique, so I'll just skip through these. So from the anterior portal, I'm now just looking with my scope underneath PCL into the posteromedial access, and then I can use an all-inside device. I can watch. I don't have to plunge all the way through. I can basically just go through the capsule, deploy the device, and then slowly bring the needle back, bring it into the meniscus body. I can watch it go into the posterior capsule again. I don't have to go too far. I can deploy the device and then tension the suture, which will get a nice compression of that material at the back. So that's really compressing the suture. And then I'm going to come anteriorly again. And for me, the most important part of the ramp lesion is the meniscotibial ligament. And so I actually want to get the suture placed on this inferior surface of the meniscus into the meniscotibial ligament. So I use all inside devices for this approach, and that tends to give a nice repair. And because I've placed the superior suture first, it lifts the meniscus up, which gives a really nice access. And so here he is post-surgery. I also did a little deep MCL repair for him as well. And that shows that it reduces his anteromedial rotatory laxity. So with that, I think I'm out of time. So I'll basically just summarize by saying that, meniscus preservation is of paramount importance. We should be looking to try and preserve the function of the meniscus when we can. The root and radial tears behave like a total meniscectomy. So again, important. These are the things that we can be aggressive with. Non-operative management generally associated with less favorable outcomes. But that doesn't mean to say that there's not a role for it. So again, each patient you have to take on their own merits. There's many techniques that are available to help her achieve our desired results. So we really have to know lots of different techniques to be able to do this. And with regards to ramp lesions, I think it's important to repair unstable ramp lesions with aiming to improve the reconstruction outcomes of our ACLs. So with that, thank you very much for your attention and happy to take any questions.
Great, Alan. Thanks very much for that excellent evidence-based talk, just what I was expecting. I would just like to now ask my co-panelists to fire out their questions, and then subsequently I have a few at the end.
Yeah, Sundar, yes.
Yeah, it's a fantastic talk, Alan. Big congratulations, because you had covered all meniscal repairs in a 40-minute talk. It was fantastic. My question is now, when you do because you told you advocate the ramp repair. So even for clinically, sometimes we get confused which is stable, which is unstable ramp lesions. So do you decide by just probing the meniscus or pulling the meniscus inside? By seeing the mobility, do you decide, or depending upon the length or where it is involved in the back side, which how will you decide?
No, I think the important thing when we think about stability is the stability of the knee. As opposed, with a ramp lesion, obviously if you have an unstable meniscus, then I think that's a different entity. You've got a meniscus tear that needs to be repaired. If the meniscus is essentially stable to probing, but you have a ramp lesion at the back, it's 2 centimeters plus, but you have increased anterior translation, a grade 2 pivot or greater, that is someone who will, for me, I will do a ramp repair. But I think if you're getting, a lot of my patients, come to me relatively chronically. So chronic ACLs, they tend to have higher grades of laxity. And if those patients have ramp lesions, particularly revision ACLs, they will get a ramp repair. I'm trying to do everything I possibly can to try and reduce the risk of re-injury to that ACL.
In acute situation, do you have any different opinion or same?
Yeah, I think in the acute scenario, if you're getting to them early, that's where, because often those patients are not that unstable in terms of laxity pattern. And then, there's an argument that with stabilizing the knee, with the blood within the joint, you may get some healing of that lesion. Then there may be an argument to leave that alone. And that's certainly the patient-reported outcomes, or at least the studies, the systematic reviews looking at patient-reported outcomes would support that approach. I think the one caveat there is that when we're thinking about ramp lesions and ramp repair, the outcome of choice is going to be failure of your ACL. They're probably going to have very little impact on patient-reported outcomes. I don't think our patient-reported outcome scores are sensitive enough to pick up any differences when you're talking about a ramp repair. So we just don't have the data to suggest that ramp repair it prevents failure, because we just don't have the numbers there. But it makes sense.
Yeah, one more question. Especially when you do have a medial meniscus root tear. When you have a good cartilage, sometimes when you see the good cartilage, decent joint space, but you see the sunk lesion. So when you see a sunk with the good cartilage, you go ahead, do under repair and protect the joint, or how do you treat conservatively with like unloading brace?
No, I mean, I think the first thing I'm going to look at is alignment. And if I'm seeing someone who's in varus, medial root tear, with already having developed spontaneous osteonecrosis, I'm a huge advocate for doing an unloading osteotomy. I worry that the meniscus repair will not necessarily change the natural history of that lesion. If it's just pain that they're getting, then I think you have an opportunity. But once you start getting structural changes in the bone, my approach would be to aim for an osteotomy. I think that's going to have a much greater treatment effect and a longevity of treatment effect.
Thank you.
Alan, so if you have an ACL tear with a ramp tear and you want to do an extra articular procedure as well, like maybe a LET, so what is your sequence of fixation in such cases? I mean, would you do ramp, stitch it, and
yeah, ramp first. Ramp first, so meniscal lesion first, ACL, drill my tunnels, pass my ACL, fix my ACL, do the LET. LET is always last.
Okay, perfect.
IPS, can
yeah, sure.
any more? Great. We just talked you a few things about decision making. Now, Alan, you nicely alluded on a few points about the surgical technique, and I'll come to it. But what about decision making? Now, typically what I tend to see, and my colleagues may perhaps the same, is that we see these young middle-aged females. So we're talking about the degenerative group. There's no doubt about the young group with root tears, traumatic, and they'll do well with whatever techniques and repair material we use. But we're talking about the degenerate ones. Now these are middle-aged. There's not much of a deformity, but they have a distinct episode where they, if you question them in detail, they had some amount of niggling pain over the years, but it is certainly an event which has aggravated the pain and not responded to a line of non-operative treatment for say 2 to 3 months. And we on MR and the features which you mentioned, we diagnose it to be a root tear. Now, what extent of osteoarthritic changes would you accept before going in to do a root repair, especially taking into account that from the natural history, we know that this joint, if left untreated, is going to deteriorate further. But what I want to know is that when can we say that no, a root repair is no longer going to help and we just need to treat it conservatively?
Yeah, it's a great question. And this is a topic of intense debate at the moment. And I'm not sure that the evidence is really there to say when you should repair. I think it's pretty clear that what we shouldn't be doing. We definitely shouldn't be doing partial meniscectomy, right? Partial meniscectomy for these patients, they do not do well. Non-operative treatment, they also tend not to do so well. But some might do okay with being in an unloader brace, injection, physiotherapy, weight loss. Okay, but the suggestion would be that repairs seem to be doing a little bit better. And then the question is, well, how aggressive can you be with that repair, and to what degree of degenerative change can you accept? And that's something. I think on the, obviously the less amount of degenerative change, the better, in which case then definitely advocate for a repair. Once you get into sort of, Kellgren-Lawrence greater than 2 changes radiographically, I think you're running into problems. And for me, I would be advocating for an osteotomy. But the other thing we often got to think about is the type of patient that you're seeing, right? You're right. For me, a lot of them are middle-aged females. They're often overweight. And, the problem we often have is, well, if I do a repair, can they manage to be on crutches and not weight bearing for 6 weeks? Is that something that is possible? If not, then we may think, well, let's do an osteotomy and get them weight bearing quickly. But again, is an osteotomy something that patient can tolerate? Are they able to manage that? Whether time off work? Do they have do they have other people they have to look after? So there's lots of aspects of the social aspect that you have to discuss with that patient as to what they want to do and what they may want to achieve, and then temper their expectations accordingly. So I think I'm not giving you a very black and white answer, because I don't think there is a black and white answer to it. The less degenerative change, repair. The more degenerative change, osteotomy if you can. And then there's this gray area in between, and that really comes down to decision making with you and your patient.
Okay, now let's talk about the osteotomy. So obviously you also mentioned a very important point, that when we diagnose a patient with a root tear and we're talking about degenerate, it's important to get alignment views. Now, if we decide that this patient's varus is more than the contralateral side, and we add an osteotomy. Now, there's a lot of work done from Korea on medial meniscal root repairs in the degenerate group, and there have been studies there with either they advocate an HTO alongside a root repair, or they just advise an HTO without a root repair. Now, what's been your experience, and what's the evidence for either technique?
So for more degenerate lesions, I'll just do the osteotomy. So, if there is not good circumferential good continuity of the circumferential fibers of the meniscus, I'll just do the osteotomy. If the articular cartilage degeneration is less than grade 3, for example, so more sort of partial thickness and not really dealing with an osteoarthritic joint, I will do a concomitant root repair at the same time of the osteotomy, understanding that it is slightly more challenging because you now have to do a root repair and trying to avoid the hardware, which can be challenging in smaller knees. So yeah, those are I think those are the main considerations that you got to have.
Okay, and yes,
the same vein, because Alan himself said that the patients which we see for the root repairs, middle-aged females, most of them are more BMI. These, if they have a more than KL grade 2, then these candidates are also not good for osteotomy. Sometimes they may not do well. They may not be happy with even H2O, open wedge osteotomy. So there are, I think these patients are, I think this is a very gray area, whether to do an osteotomy or do a root repair or a combine. Still, we don't know, because some of them have even neutral alignment. So in these cases, really we get confused whether to do an osteotomy or root repair, or just treat conservatively or go ahead for a TKR in future. Alan, your opinion on this, please.
Yeah, I know. I think you're absolutely right. I mean, they often do not fit into the ideal criteria for an HTO or for a root repair, and it's a diagnostic and treatment challenge. There's no question about it. I think I go back to what I said. I think is what I can say with certainty: don't scope and do a meniscectomy. That is not going to help them. It's probably going to make them worse. Okay, so then it comes down to, can you do an osteotomy? Do they have appropriate alignment for that, and can they manage with the post-operative treatment? And some of them will do very well, and I think it's about tempering their expectations. I think understanding that pain will be an issue for them. It's not a quick fix, and it's something that it will get them through. And our take on this is that we're always much more aggressive with osteotomy than doing unicompartmental knee replacement, for example, because after an osteotomy, you've always got somewhere else to go if you run into problems. And our arthroplasty colleagues would be much happier to revise an osteotomy to a total knee than revising a uni to a total knee. So that's just our sort of ethos here at Western. But for sure, I think joint preservation is key. And again, it comes down to that conversation with your patient.
What's your view on centralization techniques alongside an extruded medial meniscal root tear?
Yeah, it's something that I've been doing more recently. And I think if you do have obvious extrusion, then adding in a peripheral suture is a really nice technique. Again, there's no question it makes it more challenging to do. Okay, it's a more challenging surgery. You've got an extra tunnel and extra suture passage to deal with. But for sure, it seems to improve things. I can talk about it anecdotally, where I had a meniscus transplant, a young girl. There's a lateral meniscus transplant. And at 1 year post-operatively, she started to develop pain, did an MRI scan, had the meniscus was slightly extruded, brought her back to the OR, did a centralization suture, and it resolved her pain. Now, that's very anecdotal. It could have been that just having the surgery and being on crutches for 6 weeks post-operatively and offloading that compartment just let the knee settle down. But I think there's some great work coming out of Korea, looking at and Japan, looking at these centralization sutures, and I think it's definitely something we have to think about.
Okay. In terms of rehab following root tears, if you look at the Korean studies, and again, they've done a large number of patients, they're saying that in this degenerate group, squatting, which is more common in the Asian continent, should not be allowed lifelong, deep squats and so on, because of the nature of the tissue and the chances of cutout and failure. Does it affect your management when you're dealing with a degenerative tear?
Well, I mean, maybe I'll throw a question back to you and say, well, how many of your patients, when you tell them never to squat again for the rest of their lives, actually follow that instruction? You know, it's nice for us to be able to put these restrictions on people. I think it makes us feel an awful lot more comfortable, but I really don't think a lot of the time it's practical for our patients, and particularly in cultures which involve kneeling and praying as well is going to be an issue for them not to be able to go into that deep flex position. So all we can do as clinicians is recommend, and I often, it's kind of funny how many patients complain about not having their last 10 degrees of flexion. It's not very functional, but they want to get their range of motion back. So, I think all you can do is really recommend to patients that maybe going into those really deep squatted positions is not going to be ideal for them, and then they have to make their adjustments accordingly.
Great. And the transtibial pull-out technique, whether we fix it anteriorly in flexion or extension, does it matter?
I do them all in flexion. I don't think it matters. I think, ultimately that's where you're going to get most tension is at 90 degrees of flexion. So that's where I fix them. I worry that if I did it in extension, as I brought it up to 90 degrees of flexion, it might put too much tension on the repair. But again, I don't believe the data is there to say one way or another in terms of clinical outcomes.
And in radial tears, do you think about adding orthobiologics in an isolated radial tear? Does it really help?
I have to say I very rarely use orthobiologics. The majority of the meniscus repairs that I do tend to be in a ligament reconstruction scenario. And so I think there's a lot of biology in the knee just by virtue of the fact that we're drilling tunnels. What's nice with the transtibial techniques is that you're drilling a tunnel right underneath the repair. So that's going to provide some blood into that area. And if I truly am just doing an isolated repair, I tend to microfracture the notch. I don't use PRP, and very rarely will use a fibrin clot. But again, it's something that it's definitely worth thinking about.
And there's one question on the chat which says, what about popliteomeniscal fascicle repair?
Yeah, so, this is something that I do infrequently, but it's in regard to time of ACL reconstruction, looking at the stability of the popliteal hiatus. And often, and this is something that Werner Müller taught me, is that he would, when assessing the popliteal hiatus, if it seemed to be a little widened, they would often put a suture anterior and posterior to the popliteus tendon just to try and close that down. So in effect, you're doing a sort of popliteomeniscofascical repair of sorts. So I will do that. I haven't done any of the arthroscopic techniques with suture anchors, like a sort of a Bankart type repair that I've seen from Korea, which I think is really it's really interesting, but I just don't think it's supported yet in the literature.
Okay, great. IPS, any other questions?
No, the chat box has been forwarded to you, so it's sorted.
Okay, great. Really, Al, thank you very much for taking time off, especially on a Saturday morning, and participating. Really, we've learned a lot, and you've had a fantastic evidence-based talk as always. So we look forward to your visit to India, hopefully for PKC and maybe another meetings in the future. So thanks very much on behalf of the society and myself.
Thank you very much.
My pleasure. Thank you very much. And I really look forward to coming to Pune again. And fingers crossed that the meeting will happen next year, but if not next year, 2022, I look forward to it.
Yeah.
Great.
Stay well, everyone. Nice to see you all. Bye-bye.
Same to you. Bye. Bye-bye.
Thank you, Alan.
Yeah, it was indeed a wonderful talk today. Friends, we are collaborating with the regional societies, and in continuation with that, Thanks to effort of Dr. Samanta, we are doing another collaborative meeting of Indian Arthroscopy Society. This time with Jammu Kashmir Orthopaedic Association, JKOA. Must thank Dr. Nasir Mir, President of JKOA, a good friend of mine, and also Dr. Rajesh Gupta, Secretary of the JKOA. We're going to talk about ACL Made Easy. The webinar is posted tomorrow at 4 p.m. On 18th October. Join in to hear the collaborative webinar between IAS and Jammu Kashmir Orthopaedic.